Okay, so the preface is we're going to talk about all of these effects that happen. Some are guaranteed to happen. We call them deterministic. Others are more random in nature, just increase in probability. We call those stochastic. Either way, all of these effects that we're going to talk about are going to be have been documented, measured, done by information taken by experiment. So the ways they measure these things matter. So let me just briefly review the ways we measure risk. We measure the ways things can happen. Okay. Number one, there's epidemiology. This is the study of disease in populations. The disadvantage to epidemiology is there's little control over variables because the world's a messy place, right? You talk about like cancer, right? Cancer in a population, right? There's a million different things that can cause cancer, right? Including like air pollution, right? Including genetic mutations, right? There's all these variables that can change and kind of muddy the waters in what's happening, right? It's hard to say what's happening to a group of people, right? And what's the cause, right? So you look at an effect, we want to learn what's causing the effect. It's harder to do that with epidemiology because there's little control over what kind of environmental or social or lifestyle variables that there are. You also need large populations required, right? If I just look at one person, if I take one person, right, and study what happens to that one person, and that one person lives to be 120 years old, right? What do I now know? Do I know if you give me no information, I study one person and they live to be 120 years old, right? What can I know? What do I know about people now? If I only have that one data point, I study one person that lived to be 120. Not that it's possible, but that according to my data collection, everyone lives to 120. 100% of my data population lived to 120 years old, right? So if I only report on that, I say, look, I got this new information. Everyone lives to 120 years old, right? You go, well, you only studied one person, right? Study two people, right? One of them lives to be 120, the other lives to be, 60, right? Right? So then I take the average of that, yeah. What is it, 40, 60, 90, right? So then the average age becomes 90, right? Everyone lives to be 90 years old based on my data, right? You need, in order to get accurate information, because what you're doing is you're taking averages over populations, you need large numbers of people, large study pools, large groups that you're studying, okay? This builds statistical reliability, right? If I take 1 million people and study how old everyone lives to, I can get a much better idea of the average age that people live to, right? If age is what I'm going to look at, the effect of aging. It also requires long time periods to study these things. You have to study these things over decades, right? Okay. Looking at like the rate of leukemia in survivors and descendants of the Hiroshima Nagasaki bombs, right? Looking at the rate of leukemia. It takes decades to study those because they have to have kids and their kids have kids and so on, right? You have to look at these large groups of people over long periods of time. Epidemiology is great. It tells you how whole populations are doing. You can get good information on whole populations, but you need whole populations to do it, okay? And you need long time periods to study these populations. Another way to do things is extrapolation, taking known data and projecting how that data would change at unobserved levels. This is extending the curves beyond what the graph, what your data tells you, extending the information beyond what your data tells you. This is just basically taking all right, so like if more radiation causes more harm and we test that, right? But we don't test beyond a certain point, let's just assume that beyond this point, more harm is caused, right? But we don't really know that because we haven't tested it. That's extrapolation. It's just saying, all right, logic's telling us that like more radiation causes more harm. So then beyond the point where we've tested, let's just assume that, yeah, even more harm is going to be caused, right? That's it. That's extrapolation. Based on assumptions that conditions and responses above or below in the known data will be consistent with the known data. And importantly, because living things are messy, biologically this is not always true. So extrapolation, while sometimes useful, can be misleading in some cases. So take with a grain of salt, extrapolated data. Lastly, direct experimentation. Direct experimentation has big advantages. This is in the laboratory setting. Big advantages include tight control over variables, because you know what your subjects are eating, where they're living, what they're doing. You measure things about them constantly, right? Because you have direct control over them. So tight control over variables. So when something happens, you can usually say exactly why it's happening. You also have the advantage, which you don't have in epidemiology, of having a control group. A control group is a group of that subject population that you keep separate from the testing group, the group you're testing on, and that you don't do anything to. Right? So you want to test how rats respond to radiation. Right? You take a control group, don't give them any ionizing radiation beyond the natural background, don't give them any, and then take your test group, right, and then do the test on them and compare the test group to the control group. The disadvantage, we're doing this on animals because, people are people and we can't just do this on us, right? So you can't take a group of people and start experimenting on them because that's bad, right? We all agree, like as a population, that's not a good thing to do, so we can't do it on people. But there are animals that share lots of similarities with us, other mammals, right? So we have to use other mammals, but these are not people, right? So animal results cannot always be validly applied to humans, right? This is like taking some, makeup and testing it on a chimpanzee, right? The chimpanzee doesn't get a rash when you put the makeup on them, so give it to people, right? Well, maybe it causes rashes on people, right? We don't know because we didn't test it on people yet, right? That's a big disadvantage to animal testing, okay? So that you cannot always extrapolate. This is another version of extrapolation. Extrapolate the data to people, okay? All right, plus there are ethical considerations with animals too and other things like that. So you got to consider those things. The best information is obtained when two or more of these methods can be applied, and then two or more methods agree with each other. Okay. Then reporting the risk. Okay. There's 3 ways to report risk. Absolute risk is the number of cases per amount of people per year, right? So you can say, example given, the number of children of women surviving the atom bombs had a risk of birth defects of 100 to 200 birth defects per million per year. It lacks specificity and linking only radiation as a cause. Then there's relative risk, ratio of cases compared to a control population. So you can say, like, the effect was twice as likely in the test group versus the control group, right? If the test group, so let's say the control group, let's talk about like maybe birth defects, right? Because they use birth defects above. Let's say 6% of people had birth defects, right, in the control group, and we gave the test group some radiation exposure, and 12% of the test group had birth defects, right? That's a relative risk of 2 to 1, right? There was twice as many birth defects in the test group versus the control group. That's relative risk, comparing the risk against a control population, which doesn't have the effect happening to them. Excess risk, number of cases beyond the normal expected in a particular group. So if I said there's a rate of birth defects of 6% in the control group and 12% in the test group, the excess risk is 6% because we went up by 6%. The risk doubled in that case, okay? But the excess risk is an additional 6% because you already had a 6% chance of a birth defect. Now with the test group, you now have a 12% chance of a birth defects. Okay, these are our 3 ways we'll be able to report risk. Okay, so we have ways of measuring risk and ways of reporting the risk. That's all the preface, throat clearing stuff out of the way. Now let's talk about systemic effects and some new terms. I've used them a couple of times, but here they are, 2 super important terms in radiation safety. We call them deterministic and stochastic. First time I saw the word stochastic, it took me a long time, a few exposures to it to start to remember the term. The word stochastic means random. That's what the word means, okay? It is the technically correct way to say random or unpredictable. Because random sometimes has a very technical meaning in mathematics, but think unpredictable too. Okay, so if you're not using it technically, the word random is appropriate. Unpredictable is also appropriate. So like cancer, that's a stochastic effect, right? You might get cancer just from living your life, right? But you also might have gotten cancer from that chest x-ray you got 20 years ago, right? We don't know. It's random, right? The effect is, there is no direct cause and effect between the environment and the thing that happens. All we can say is that, like, if you got one chest x-ray 20 years ago, that's some risk, right? If you get a chest x-ray every day for 20 years, that's more risk, right? You're more likely to develop cancer if you get x-rayed every day versus only one time in your life, right? That's a silly way of talking about it, but that's what we mean by stochastic. It's just the likelihood of something happening increases. Yes, please.
Is it also statistical then?
Yes, absolutely. You'd see, if you took this as a population, you'd see more things occurring in the population, right, with more exposure. So deterministic means determined by the dose. We say with deterministic, the thing is certain to occur once you pass a threshold. So remember last time we talked about the graphs, the response curves. We talked about threshold, non-threshold, linear, non-linear. These are going to come up in this talk, okay? All of these linear, non-linear, threshold, non-threshold. Okay. And not to give away the game too much, but deterministic effects are associated with early effects of radiation, usually associated with large or acute doses of radiation. Stochastic effects are mostly associated with long-term or late effects of radiation, associated with small doses or chronic exposure to radiation. All right, so given these two categories, let's talk about deterministic effects today. Next Friday, we'll talk about stochastic effects. All right, so our deterministic effects, they increase in severity with increasing dose above a threshold. Help me out. What's this idea of a threshold? What do we mean threshold? Jennifer, you look like you got something to say.
What is a threshold?
Yeah, what's a threshold in this
Like the
context?
point that the effect happens?
Yeah, so below that threshold point, what happens?
Nothing.
Nothing, right? I give you some radiation below the threshold, nothing happens to you. Once I pass the threshold, boom, the thing starts to happen. Whatever the thing is we're talking about, it begins to happen now. And as we go up and up and up past that threshold, the effect gets worse and worse and worse. But eventually it gets as bad as it can get, and then the graph will kind of shoulder off. We talked about the graph curving up and shouldering off, right? So, I'll just keep saying this, deterministic effects are associated with a threshold, and they're associated with a nonlinear response, the curved graph. So threshold nonlinear response curves. And again, they're considered certain to occur to the exposed individual provided the threshold dose has been reached. Deterministic effects only occur after large doses, such as those used in radiation therapy. It's possible to cause deterministic effects in C-arm fluoroscopy, which is usually used in surgery, and angiography, which the limited X-ray tech does not perform. So in the diagnostic X-ray room, in the regular X-ray room where we're just taking plain film, still image X-rays, we don't use enough radiation to cause deterministic effects. Okay, so this is outside of our applicable range, but it's, again, still important to talk about these things. Some examples of early effects that are deterministic include erythema. What's erythema? Reddening of the skin. Good. Erythema is reddening of the skin. It's the fancy way to say sunburn. Erythema. Decreased blood cell counts, so blood cell suppression. Epilation, which we used that earlier. Epilation, what was epilation?
Oh, extra.
Hair loss.
Oh, yeah.
Good. Epilation's hair loss. Good. Fibrosis, the production of fibrous tissue. Atrophy, the loss of function and size of a tissue. Sterility or decreased gamete count, a decrease in the production of ova or sperm. These are generally radiation therapy level effects. Diagnostic levels of radiation usually cannot cause deterministic effects except in extended fluoroscopy, such as C-arm and angiography. Most early effects are deterministic, meaning most early effects are determined by the dose. We know when they're going to happen. They have a threshold. As long as you stay below the threshold, the thing doesn't happen. There is an example of a deterministic effect with a threshold, but it doesn't show up early. Early means days or weeks, hours, days, or weeks, right? There's an example of a late effect that is deterministic, and that is the cataract of the lens of the eye. We know the threshold dose for that. I'll give it to you later in the notes. So that's the only good example. It's deterministic, but happens later on in life. It's just because it takes years for the damage to manifest. The damage happened early, but it takes years for it to show up. Yes?
So, I can't pronounce either one of them.
Stochastic?
Stochastic
Uh-huh.
is the one. Can you just?
Yeah,
tell
absolutely.
us
So let me
again?
backtrack.
Yeah.
So here up on the screen, deterministic effects.
Yeah.
We know when the dose is going to happen. Deterministic effects have a threshold. Deterministic effects are mostly associated with large doses of radiation. And almost all the deterministic effects, except for one, happen early after the exposure. You know, like you go out in the sun, you get a sunburn like that day, not like 3 weeks later, right? That's like an early effect, right? If you went out in the sun and got cancer 30 years later, that's a late effect, right? Okay. So deterministic effects, there's a threshold for it. We know when it's going to happen. They're mostly associated with early effects, things that happen soon after. Stochastic effects, random in nature. They're random. They don't have a threshold. Any amount of radiation can cause them in principle. And they're mostly associated with the late effects, the things that happen later on in life, like lifespan shortening or cancer. We won't talk about stochastic effects today. We'll do those next time. Today we're focusing just this. No, this is why, right? Because it's sort of gets confusing, right, when you have them to two.
Yeah,
We want to split them up.
the difference.
Here's one needless complication that I don't like. Deterministic effects are sometimes called non-stochastic. And that troubled me when I was a student because I was told, here's stochastic, here's non-stochastic. And remember which one's which, right? I didn't like the use of the same word being thrown around, right, to mean two different things, so one with the word non in front of it, right? So I just say deterministic and stochastic nowadays, okay? But you should know that deterministic also means non-stochastic, because non-stochastic just means not random. And if it's not random, we know when something's going to happen, right? Okay, follows a pattern. Okay, back to deterministic. So we talked about early effects. We talked about, early effects. They follow a nonlinear threshold response curve. Below the threshold, nothing happens. Above the threshold, something happens. And the curvature is nonlinear. A little bit more dose does not equal a little bit more response. A little bit more dose equals a lot more response. So you get the S-shaped sigmoid curve for your graph, your response graph. So I'm going to move a little bit forward now and move to the section called Early Effects of Radiation. So that's what we're doing. We're doing the deterministic stuff. So early effects equal deterministic for the most part. There's one example of a deterministic effect that happens late. That was cataract. All right, so our early effects, we're going to talk about radiation syndromes and all that fun stuff right now, which is actually kind of, I think intrinsically interesting, but we'll see how you guys take it. Early effects, those that manifest within hours, days, or weeks after radiation exposure, where late effects take months or years. So let's say you cause damage to 10 cells in the body, right? 9 out of the 10 of them are going to be able to repair themselves, right? The 10th one won't. So to translate that in another way, 90% of somatic damage is repairable. The 10% that is not repairable is permanent and becomes cumulative. More exposure equals more damage. So there's always this like roughly 10% of damage that's not fixable. Okay, so our early effects. Remember pardon me. Early effects of radiation are somatic, not genetic. Someone translate that into English for the rest of us. To say something is an effect is somatic, not genetic. What are we saying?
Man-made?
Not man-made. I want to pick on somebody. Marissa, can I pick on you? Please. What do you think? Somatic versus genetic? Everyone else should be thinking about it too, because I'm going to put someone else on the spot here pretty soon. Any ideas? I know I put you right on the spot. It's okay. Emily, I'm going to put you on the spot now. Somatic versus genetic, what are we saying? Let me give maybe a little hint that might help you. I'm going to stick with you for a second, okay? But everyone else think about this. You have two types of cells in your body. You have somatic cells, and you have a very small part of your body that makes genetic cells, okay? The part of your body that makes genetic cells are the ovaries and testes. So, what are genetic cells used for? Reproduction, right? So genetic effects are those effects that happen to, Emily? Genetic cells are the ones that are ova and sperm, right? Those are going to make new people, right? If you damage those cells, that damages your what? Your genetic cells are ova and sperm. Those are the ones that make the offspring. If you damage those cells, what are you damaging? Your offspring. I just said those cells make offspring, and if you damage those cells, then you're going to be damaging your offspring. Okay? All right. Thank you. You're off the hook, Emily. Thank you. Okay. So genetic cells. The genetic part of your body is the part of your body making genetic cells. Those genetic cells are used to produce offspring. If you damage those cells, you damage the offspring. So genetic effects are the effects that happen to our offspring. Okay. The other part, most of the rest of your body, all the cells except for the ovaries and testes, right? The whole rest of your body are called somatic cells, okay? Your somatic cells are you, right? So if you damage somatic cells, what are you damaging? You, right? The body, right? You, the person, okay? So early effects of radiation are associated with somatic damage, damage to the person, not damage to the offspring. Make sense? This is especially clear in males because males reabsorb and or otherwise destroy the sperm that's produced, right? So whatever sperm a male has now, 90 days from now, it won't be the same sperm, okay? So You damage the male's sperm, damage the male's whole body, right? Give him whole body exposure. The body's going to be hurt. The genetic cells are going to repair and be new in 3 months from now. Okay. A little harder to say for females because females just have ova and there they are, right? And they can be damaged. But we associate early effects with somatic, meaning effects that happen to the body, the person, the living thing, right now, not their offspring. Okay. We associate early effects of radiation as being deterministic, not stochastic. So what are we saying there? Everyone's trying so hard not to make eye contact with me. Vanessa, what are we saying? Deterministic versus stochastic? That's okay. I know I'm putting you guys right on the spot. All right, I'm gonna jump from you. Stephanie, what are we saying? What's a deterministic effect? Absolutely, it's predictable. It's the word, and it's in the word, right? Deterministic means determined, right? It's determined by the dose, right? Predictable, right? We know when it's going to happen, right? Once you pass a threshold, whatever that threshold is, the thing's going to happen. So not stochastic, deterministic. The responses are nonlinear. All right, Miriam, tell me something here. What's nonlinear mean? I think you're on the right track. So nonlinear tells us the effect gets much worse with a little bit of an increase in exposure, right? Linear would say the exposure doubles, the effect doubles. The exposure doubles again, the effect doubles again, right? But these aren't linear, right? Nonlinear says a little bit more exposure equals a lot more response. That's why the graph takes a steep curve. Right after you pass the toe, the threshold point, the graph takes a steep curve upward, okay? That's saying the response goes up by a lot with only a little bit more exposure. And then lastly, threshold. Any ideas about threshold? All right, Karina, tell me something about threshold. What does it mean to say a response has a threshold? Aurora, you're next.
You did say something about nothing happens.
Okay. What do you think, Karina? You want to agree with that, or you want to punt the ball to someone else? Okay. What are you thinking?
I know what you're talking about. It's something you said it doesn't happen.
Right. So a threshold says below a certain amount of exposure, nothing happens, right? Above a certain amount of exposure, it's gonna happen. Okay? That's what deterministic means, right? Deterministic literally means we know when it's going to happen. Now, deterministic doesn't mean it has a threshold. It's determined, right? We know when it's going to happen based on experiment, right? We can say that, yeah, everyone's going to get decreased blood cell counts at 250 millisieverts, right? That will happen no matter who you are, okay? Good. All right, so early effects are somatic, deterministic, nonlinear, and demonstrate a threshold, okay? All of these things apply for deterministic. Early effects. Late effects will basically be the opposite of this, by the way, okay? So keep this for early effects. Now that you've got that, let's talk about the actual effects themselves, okay? So these are the threshold doses. These are saying below this dose, the thing doesn't happen. Above this dose, it's going to happen, okay? So 250 millisieverts for decreased blood cell counts. And I know these are just numbers with effects attached to them, but work on remembering these, okay? Work on practicing remembering when these happen, at least a few of them, okay? So like, you know, I definitely want you to remember the threshold for human death, the LD 50/30. I want you to remember the lethal dose for 100% of the people. We got to start working on remembering these things. These are important. All right, but anyways, 250 millisieverts, decreased blood cell counts. 500 millisieverts, half of the lymphocytes are gone. Lymphocytes are useful for what? It's not blood count, because that would be leukocytes. Your immune defense, absolutely, right? And if you don't have a good immune defense, what's going to happen to you? You're going to get sick, right? You're going to get opportunistic infections taking hold, right? So it's not the radiation that's going to kill you, right? In this case, it's the infections that you can't fight off, okay? At 500 millisieverts, that's going to start happening. Half of your lymphocytes. That's a big number to lose half of all your lymphocytes. At 1 sievert, or 1 gray, if you guys are used to hearing gray, right? But we know gray and sievert now are sort of interchangeable for x-rays. At 1 sievert, that's the threshold for human death. You give a big enough population of people, all of them a full gray or sievert worth of radiation, someone's going to die. Okay, that is the point over which we now have possibility for death. You'll learn that is the point past which the radiation syndromes begin. Okay, I'm working up to try to get to radiation syndromes today. We'll see how we do. 3.5 to 4 sieverts is our LD 50/30. This is the coin flip chance of dying, okay, after this exposure. Okay.
So you said if it goes over this, the effect happens.
Yes.
If it goes over?
Yes. Are you thinking about something? Because I think I know what you're thinking about. I don't know, maybe. All right. So maybe you're thinking about this, maybe you're not, but keep this in mind, right? If the lethal dose, so see where the laser pointer's at, right at 1 sievert right now, right? The lethal dose, somebody can die over 1 sievert. If you give someone 1 sievert, they could die, but what is also happening to them? What other effects happen below 1 sievert? What are the two effects happening under 1 sievert? Decreased blood cell counts and 50% loss of lymphocytes. Yeah. So on top of the fact that they passed the threshold for human death, they've also passed the threshold for lymphocyte loss. They've also passed the threshold for decreased blood cell counts. It's not like we get to skip those other two and just go to possibility for death. Those other things happen, okay? So everything, if you get to the LD 50/30, right, everything that's below that point will also happen, okay? Get to the lethal dose for everyone, right? Everything below that point is happening, okay? It's going to become important when we get to radiation syndromes, right? Because when I talk about central nervous system syndrome being the worst one, the other ones happen before that, okay? Or also as well, right? Once you pass a threshold, everything below that threshold is going to happen. Some other threshold doses. Another mild little preface. All of these effects are whole body. Okay, we mean these effects will happen if you give this amount of radiation to the whole body, okay, which just doesn't happen in radiography, okay? We never x-ray the whole body, and when we do, we're not using anywhere near these threshold doses for the most part. I mean, you can get near some of these threshold doses in CT and fluoroscopy, but generally speaking, these whole body effects are not likely in radiography because we're not x-raying the entire body, okay? So keep that in mind. So partial body effects. At 50 millisieverts, chromosome aberrations. Aberrations just means visible damage to the chromosomes. You take a picture of the chromosomes during metaphase, and they look messed up. We saw the photomicrograph earlier of the damaged chromosomes. 2 sieverts, erythema, reddening of the skin, and 3 sieverts, hair loss. If you gave 2 sieverts to the whole body, what have we passed the threshold for? If this were the whole body, though, because these are partial body, right? So if I gave 2 sieverts to the whole body, what can happen to the person? They could die, right? But given to just a part of the body, it causes erythema. Okay, they're not going to die, in other words. So there's partial body versus whole body. This is a very complicated conversation to have when you start talking about partial body versus whole body effects, right? Most of the time when we talk about radiation exposures, we're talking about whole body effect, right? We're talking about radiation exposure to the whole body. When that happens, what happens to the body, okay? But more commonly, there will be partial body exposures, which is the most common thing in radiography because we're not x-raying the entire body at one time. Okay, so yeah, you can get away with giving somebody 3 sieverts if it's concentrated to a small part in the body and not killing them, okay? It'll cause epilation, hair loss, but it won't kill them, okay? All right. So here's a picture, 2 pictures. This is erythema up top, erythema of the skin, reddening of the skin. You see the skin is beginning to slough away. The layers of tissue are being destroyed and are now sloughing away, leading to cancers of the skin, neoplasm cancers of the skin. This is, they say, serious skin burns to patients have been reported in modern times for cardiovascular radiography, interventional, which is like surgical radiography, and C-arm procedures that go for very long periods of time. For that reason, as an RT, when I'm working with a physician, I'm required to notify them once we reach 5 minutes of beam on time, because we don't put the beam on continuously, but once we reach 5 accumulated minutes of beam on time, let them know. But, you know, they're in the middle of someone's heart, right? They got to fix the thing, right? So you say, all right, we've reached 5 minutes. They cool deal. And we keep going, okay? And when we just have to document every time we reach a 5-minute marker. Okay, the machine's required to report, kind of alert us. We're required to report to the radiologist. And, you know, we're doing everything we can to time distance shielding, right? Minimize the amount of time around that rate for the patient to be exposed to that radiation. But we just document it, okay? Sometimes procedures take long periods of time, right? Surgeries take different periods of time depending on who the patient is and how complicated they are. This is a similar idea. Okay, but anyways, that's an example, picture example of erythema leading to cancerous lesions on the skin. Gonadal early effects. These are doses, if given to the gonads only, would cause gonad effects. 100 millisieverts to the testes on the male. Decreased sperm count. Takes a couple of weeks because you already have mature sperm. Remember our talk, mature sperm are more radioresistant than baby sperm, right? Immature sperm, right? So it takes a few weeks. The mature ones are not going to get hurt, but a few weeks later, all those immature ones that were going to be mature sperm cells, they're all hurt, and they're not going to get to grow up to mature sperm cells. So if you measure sperm count a few weeks after the exposure, you'd find a decreased sperm count. 100 millisieverts given to the female, to their gonads, suppressed menstruation. The whole ovulatory cycle, menstrual period, may be suppressed for maybe 1 full cycle. 2 sieverts, if given to the gonads in the male or female, will cause temporary infertility. Takes female a cycle or so, a male a full 90-day recovery period. 5 sieverts, if given to the gonads, permanent sterility. All the ova dead and no more sperm cells being produced by the male. But keep in mind, 5 sieverts, if given to your whole body, passes the LD5030 threshold, right? So it's already like it's a high amount enough. If given to the whole body, would cause death. If given to coin flip chance of death. If given to the testes, then or ovaries, then permanent sterility. Also, because the radiation has to pass through the skin, you're passing the threshold dose for erythema of the skin, which is 2 sieverts, right? So now you've got, the male's got big swollen red testes, epilation, hair loss, the whole gamut, right? Females, pelvic area, epilation, hair loss, reddening of the skin, radiodermatitis, plus permanent sterility, okay? So like, remember, once you reach the threshold, everything that could have happened under that threshold is also happening, right? The effect you're talking about, plus everything that happens less than that, at lower than that threshold. Lowest radiation dose that causes a biologic effect. We've said this one. This is 50 millisieverts. Visible chromosome aberrations. If this is a one-time exposure, by the way, 50 millisieverts as an amount of radiation, that is you guys should know this. This is your yearly limit, right? So if this were given to you all at once, this would be is it. That's all you can get for the whole year. Okay, that's your prospective yearly dose limit. Bless you. If given to your patient, it can cause chromosome damage. If given to them all at once, it can cause chromosome damage. If given to you too, it could, but hopefully you're staying out of the way of the beam, right? And 500 millisieverts, which, let's go back, 500 millisieverts is 50% loss of lymphocytes. That is your acute exposure, one-time, once-in-a-lifetime emergency limit. Okay, this is usually used for first responders. But if they got that first responder who goes rushing into the nuclear power plant that just exploded, right? If they get their 500 millisieverts and get out of there without getting any more, right? They're going to lose half of their lymphocytes and show decreased blood cell counts, right? They're going to have visible chromosome aberration. They're going to have damage caused by this, right? That's why it's a one-time deal. That's why it's like, you can't do that again. That was bad. Don't do that again, right? But you needed to do it to, because you're the first responder. Someone's got to do it, right? That's what you signed up for. Okay, yeah, so leaving them vulnerable to infection for some period of time afterward. Okay. So that's good. Good there. Let's circle back around to our lethal doses. We gave the LD 50/30. That LD 50/30 was for people. Okay. LD lethal dose, bless you, expressed as capital L, capital D, with a subscript X over Y. X is the percentage of population that will die, and Y is the period of time that is expected to happen over. So the lethal dose 50-30 says, whatever that dose is, 50% of the population dies within a 30-day time frame. So coin flip chance of dying within a 30-day time frame. Now, interestingly, this is different for different animals, which I think is just kind of cool. So here you go. Humans, we're not that strong. We get 3.5 to 4 gray. That's our LD 50/30. Give us 4 gray, coin flip chance of dying. Okay. Monkeys, and presumably other primates, are similar because we're just smart hairless monkeys, right? We're primates, right? So we're smart hairless primates. So our LD 50/30 is roughly the same as other primates. But rats and mice, check them out. 9 gray. They've been around for longer. They're more specialized animals.
So
they can handle more. Yeah. Yeah, you give a human 9 gray, and that's for sure death, right? You give a rat 9 gray, and that's a coin flip chance. Yeah, they have a coin flip chance of surviving it. Yeah. Kind of cool, right? Rats and mice. Other rodents, presumably, too, right? We're not testing it. We didn't go test all the rodents. We tested like some of them, right? But presumably other rodents. Check out the goldfish, though. Look at these guys, 20 gray, okay? But think about fish. Fish have been being fish for a long time, hundreds of millions of years, right? People have only been peopling for a couple million years, okay? Right? So you see the trend here, right? The longer an organism has been around, the more resistant it is to radiation, right? Our insects were some of the first organisms to be up on the land doing organism stuff, right? More than 20 gray, right? That's what you hear about, like cockroaches being able to survive a nuclear blah, blah, blah. By the way, they can't survive the nuclear blast. No one can, right? It just vaporizes things. But it's the radiation afterward that they can, in principle, survive, okay? Greater than 20 gray. So more than 20 gray, that's their coin flip chance of survival. I don't even know what the lethal dose is for them. It's for 100% of them. It's more than that, though. Maybe not measured. Highest measured dose a human has survived is 8.5 gray. Actually don't know what human and under what circumstance. Could have been Chernobyl, could have been Hiroshima, Nagasaki, could have been some other radiation disaster. I know of other ones. There's been plenty of. There's been at least one big disaster that happened to just a small group of scientists leading up to and after World War II with an unused plutonium core after the Hiroshima Nagasaki bombs, which killed a big group of people. But yeah, the highest measured dose a human has received, then recovered from, was 8.5 gray. So that's above the lethal
What length
threshold.
of time is it, like, that between exposure and what's considered survival time?
Oh, good. So it varies based on exposure, right? As long as the organism survives, and as long as they recover. So you're asking like,
Their blood count, or what,
as long as they stay alive
for how long?
till the end of their life, they die of natural causes.
Okay.
Yeah. So if the person dies of natural causes, we say their death was not caused by radiation. Yeah. So they have to survive and recover. Their blood counts have to come back to normal, right? Body functions have to come back to normal, and we say they've survived. Yeah. Yeah. You know, if they survive for 3 weeks and then die from infection, they died from the radiation exposure.
But if they died, like, 20 years later, but it was, like, leukemia or something.
Right. That's a stochastic effect, not considered an early effect from radiation. In other words, if they received a large amount of radiation now and then died 20 years later, the death was not directly linked to the radiation exposure. Yeah. You're hitting on a really important and crucial idea, though, right? It's like, what do you mean survived, right? Yeah, you're hitting on an important thing, though. Okay, so 8.5 gray, highest dose of humans received and lived from it, recovered, in other words, right? The LD 100, it's 100-60, so it's a 100% chance of dying over a 60-day time frame, is 7 gray. 6 to 7 gray. So the reason why we say 6 to 7 gray, by the way, it's 7 gray if they can get medical treatment. It's 6 gray if they can't. Okay? So really it's 6 gray. 7 gray is just like if you can get them IV fluids and IV nutrients. The reason why, which you'll come to find out in a little bit, is there is a syndrome called gastrointestinal syndrome, GI syndrome, in which the intestines are permanently damaged and lose their ability to absorb nutrients. You need medical treatment to keep them alive and keep them from starving to death. All right, so one more time, your lethal doses for humans, 3.5 to 4 gray is your LD 50-30. Your lethal dose for everyone is 6 gray without treatment, 7 gray with treatment. But again, these are just statistics. Obviously, we just said somebody survived 8.5 gray, so somebody went past that lethal threshold and survived it. But that's, a person. Even if it's 100 people or 1,000 or 1,000,000 people, right? There's like 9 billion people on the planet, right? And so most of them, if given that much, would pass the threshold for death and then die. All right. Let's do our radiation syndromes now. Now that we know our lethal thresholds, let's talk about radiation syndromes. The first, so acute radiation syndrome, ARS, okay? There's going to be a few different versions of, getting too far. A few different versions of this that we're going to need to go through. Hematopoietic syndrome, GI syndrome, and central nervous system syndrome, these 3 versions. However, all of those are life-threatening. So ARS is a life-threatening syndrome that happens above the lethal threshold. And what's the lethal threshold? 1 gray, right? 1 gray, 1 sievert, however you want to talk about it. Anyways, below the lethal threshold, you don't have a likelihood of dying, but you do have a likelihood of something bad happening below that lethal threshold. So nausea, vomiting, and diarrhea syndrome, NVD syndrome, is a syndrome that happens when you stay below the lethal threshold, but above a certain amount. So it's from 1/2 to 1 gray. So 500 milligray is sort of the threshold for NVD syndrome. Humans subjected to high amounts of radiation not exceeding 1 gray experience nausea, vomiting, and diarrhea, accompanied by a feeling of general malaise or weakness. Malaise is that, like, I feel terrible feeling when you have like a viral illness. right? The whole body, like, everything hurts, malaise. These symptoms will subside after a few days with no further complications. Everything sort of goes back to normal. Now, we've passed a couple of thresholds, right? So if you kind of go back, so let's say it's up to 1 gray. Stay below 1 gray, but up to 1 gray. We've lost lymphocytes. We've lost blood cell counts. Okay? We've got chromosome damage, right? All of those things are happening, and they're having nausea, vomiting, and diarrhea. So even though the nausea, vomiting, and diarrhea symptoms are going away, because we passed the threshold for lymphocyte and blood cell blood cell loss, let's say that. Blood cell counts going down. Because we pass those thresholds, those things are also going to happen. So now they're also at risk for opportunistic infection, right? So keep that in mind. Even just because we're saying nausea, vomiting, and diarrhea syndrome doesn't mean the other things aren't happening too, okay? And this is going to be the story. Once we get above 1 gray and start talking about, hematopoietic syndrome, GI syndrome, central nervous system syndrome, you've passed this threshold too. So they're also having nausea, vomiting, and diarrhea. They're also having decreased blood cell counts, and you've reached the other thresholds. So, okay. So all these are cumulative. They all sort of stack on top of each other. It starts to get really bad really quick for these people. All right. Before I jump into the acute radiation syndrome, let's briefly talk about the stages of any illness. Okay? There's a prodromal stage. Usually, not any illness, but a lot of illnesses share this. Usually you feel sick for a while after the illness begins. That's prodrome. Then you're like, I feel better, right? COVID has prodrome, where you're like, I'm a little sick, and then I can feel better, and then I get really sick, right? So prodrome is like, I'm a little sick. Then you go, I feel okay. That's not so bad. Last night wasn't so bad. I'll be okay, right? That's called the latent period, when you're like, I feel okay, okay? And then all of a sudden, you are very, very sick, okay? That's called manifest illness. And then you're sick for however long it takes to stay sick for. We'll talk about lengths of time in a moment here. But manifest illness, okay? And then you either get better or you don't. So stage 4 is death or recovery. The duration of all these stages is inversely proportional to the dose received. All right. So Aurora, I said I was going to pick on you and I never did. So here you go. What does it mean to say the duration of all these stages is inversely proportional to the dose received? What's that saying?
That is not proportional.
Ooh, what's proportional? Let's break this down. What does it say? What does it mean? What does proportional mean?
When it's the same?
Sort of. The proportional is telling us
It matches up.
if an effect was proportional, that would mean as one number goes up, the other number goes up, right? So if the dose went up, the time for the stages would be longer, okay? But we said inversely proportional. Opposites. Opposites, right? One goes up, the other goes down, right? You're exactly right. So inversely proportional says when the dose goes up, the time between stages goes down. So the higher your dose, the shorter these stages are, okay? The quicker you get sick, in other words, okay? That's the idea. The longer these stages take, or rather, the lower the dose, the longer these stages take. The higher the dose, the shorter these stages are, right? So if you've got really high dose, you're going to get to death really quickly, right? That's the idea, right? The higher your dose, the quicker you get to the death point. These are all life-threatening, right? All of these, once you get past 1 gray, all of these are life-threatening. So yeah, for acute doses of above 1 gray, the victim gets nausea, vomiting, and diarrhea syndrome. They get fever and faintness during the prodrome stage, which lasts hours to days. So there's your prodrome. They get sick for a little while. And then there's a latent period. So these symptoms then subside. The patient feels a false sense of recovery. So think about that, right? You get a big dose of radiation, because I don't know, you accidentally stepped inside a nuclear reactor or something, and pretty quickly, hours later, you're starting getting nausea, vomiting, and diarrhea. You're running a fever. You're feeling weak and faint, right? And that's going to stay like that for hours or days, okay? But then a couple of days pass maybe, and you're like, oh my gosh, that sucked, but I'm better now, okay? That's your false sense of recovery. That's the latent period. Oh my gosh, that sucked, but I feel better. Ooh, glad that didn't kill me, right? And then so you get this latent recovery, and then all of a sudden, a couple of days after, right, after you felt better, the latent period passes. The prodromal symptoms, nausea, vomiting, diarrhea, fever, malaise, all come back. Worse this time, okay? With additional life-threatening symptoms characterized by the subsyndromes I'm going to be talking about next, okay? Depending on how high the dose was, one or more of these sub-syndromes will begin to happen.
So that's what happens when people are like recovering from chemo?
Yeah,
Like when they have cancer?
I mean, that's
Like,
not
so 6 months
radiation.
they feel better,
Yeah.
Then they start getting sick again.
Yeah, you're on the right track. 'Cause it's not radiation, it's chemical treatment, but it's the same sort of idea. Yeah, absolutely. Because it causes harm to the body, right? Anything that's causing harm to the body.
Cancer cells, but your good cells as well.
Exactly. And so the patient's going to feel these similar symptoms. Absolutely. Yeah, and then they get these prodrome, latent, and then manifest illness stages potentially. Yeah.
But you pretty much have to know that you were exposed to it, right? You couldn't just randomly walk into a room that you didn't know you were exposed to radiation for it to be treated the way, because nausea, vomiting, that's kind of like a general symptom.
Absolutely.
And they don't really check or screen for that.
Absolutely.
They're checking and screening for like it wouldn't show up in your lab.
No, you'd have to know.
Yeah.
You'd have to know you were. I mean, a good physician would get a good enough history on you of where you've been and what you've been doing to figure out, oh my gosh, I think you've been exposed to a high dose of radiation, right? Like if you work in a nuclear power plant and then like some weird thing happened that you didn't, you were just like, I don't know. I walked in that room and that light was blinking and I just wasn't paying attention.
Exposed and then got knocked
Right,
out after.
right. Someone with a good enough history taking ability would be able to figure out when and where, why this is happening. But yeah, as you just said, like let's say you didn't know, because remember you can't taste radiation, you can't see it, you can't hear it, right? You can't feel it, right? So you could be exposed to it. We could be all being exposed to lethal amounts of radiation right now, and we'd be none the wiser. Okay, and a couple hours later, we'd start to have nausea, vomiting, and diarrhea, and all these things happening, right? And we wouldn't know, right? So unless you know that you were exposed, how do you don't know what's causing, right? Because exactly as you're just saying, right? Nausea, vomiting, diarrhea, fever, malaise are symptoms of lots of different things, right? So yeah, you'd have to know. You'd have to know the exposure happened. But luckily, these things are rare enough that we usually know when it has happened. Like if it happens to you, you know when it's happened, right? Because some disaster has happened and you got exposed, right? But yeah, it's hard. You think about the people that were at the Chernobyl incident, right? They didn't know, right? I mean, they didn't know they were being, after the fact, they were told they were exposed to lethal amounts of radiation. But going in, they didn't know, right? You can't taste it, feel it, smell it. So what are you going to do, right? You don't know any better, right? And there was no Chernobyl before that, right? So there was no like precursor to that in history to say, hey, maybe don't go into the power plant that just exploded, right? So yeah, but you're absolutely right. You'd have to know that it has happened because these syndromes they look like a lot of different things. Yeah, they really are. Because the body's responding in a very similar way to harm, right? Pretty much no matter what the harm is, the body's responding in kind of a similar way. Yeah. Okay. Good. So these subsyndromes in the manifest illness stage can last from hours to months. Just a couple hours all the way to months after the exposure. Remember, these are all life-threatening, so you can have death happening after potentially months after the exposure. That's why we talk about the LD 100-60 days, couple of months. Okay. Followed by the fourth stage, death or recovery. So yeah, after a couple of months, maybe you recover, maybe you die from the radiation subsyndromes that you're experiencing. It really depends on the person and the treatment they receive afterward and the amount that they've been exposed to. Okay, so given all that, let's talk about the 3 different subsyndromes that are all happening at 1 gray and higher. These are categorized according to the most immediate cause of death. Okay, so we have hematologic syndrome or hematopoietic syndrome. This is the one that deals with blood cell formation. We have gastrointestinal or GI syndrome, and then central nervous system syndrome. And these each have a threshold we'll get to talk about. If you have your notes out, you can maybe look ahead if you'd like and see the thresholds, but let's talk about the first one first. Starting at 1 gray. So remember, 1 gray is the lethal dose threshold. So starting at 1 gray, the subsyndrome hematopoietic syndrome takes over. The risk of death here is caused by damage to bone marrow tissue. Why do we care about bone marrow? Kylie, say what you said louder. It produces erythrocytes, right? It's where our blood cells are being formed, in other words, right? So if you're damaging where the blood cells are being formed, then the cells will never mature to become grown-up blood cells, right? So on top of having a decreased blood cell count, because that already happened, you already killed your mature blood cells, you're also destroying the young, immature ones that will end up being mature blood cells, okay? Severe depression in blood cell counts results in anemia because of lack of red cells, hemorrhage because of lack of platelets, and serious infection because of lack of leukocytes. The immediate cause of death in this case is most likely to be opportunistic infection, multiple severe infections. You're going to die from staph or strep, one of those two, right? Because those are like, you swab your skin right now, you're going to grow out staph or strep, you know. So we have staphylococcus, streptococcal bacteria on our skin all the time, right? And when they get into our body does a pretty good job of doing some kung fu and fighting them off, right? But when you don't have the kung fu anymore, right? When you don't have your immune system to defend you, those things get in and they will get in and do their thing, okay? They will cause infection. Viral infection too, right? COVID, influenza, right? Common cold viruses. Those are going to do their thing when we don't have the ability to fight them off. Okay, so the risk of death above 1 gray, or like right at 1 gray and above, is mostly due to opportunistic infection. So again, that's 1 gray. Go up now to 6 gray. So from roughly 1-ish to 6 gray, that's where you have blood cell syndrome, hematopoietic syndrome. Once you get to 6 gray, what was 6 gray the lethal dose number for? Lethal dose for how many percent? What percent? Without treatment, lethal. It's a lethal dose for people. How many people die if you give 6 gray to a group of people? All of them. It's 100%. It's the LD 100, right? That's without medical treatment, of course, but 6 gray, okay? So at 6 gray, this is why 6 gray is the lethal dose for everybody, because at 6 gray, you start up with GI syndrome, okay? So by the way, remember, if you're getting GI syndrome at 6 gray, you've gotten 6 gray, which means you also had the blood cell syndrome that started at 1 gray, and you also have nausea, vomiting, and diarrhea syndrome, and you also have everything else that happened below that too, okay? So remember, these are cumulative. They stack on top of each other, right? You don't just get to skip to this one without going through the others too. So now you're going to die from opportunistic infection, and you're going to die from all this stuff that we're about to talk about, okay? So these get worse, right? These, again, none of these are good. These are all life-threatening. Risk of death caused by damage to the lining of the small intestine. Briefly, what's the small intestine useful for? What's it doing for your body? Yes, but your stomach does most of the digestion. The small intestine is doing what? The absorbing. Thank you. The small intestine is doing the absorbing. Most of the water, most of the nutrients are being absorbed in the small intestine. So it goes mouth, esophagus, stomach, small intestine, then large intestine, right? Large intestine's for elimination. Stomach is for digestion. Small intestine in the middle is for absorption, okay? You've now damaged the small intestine, okay? And importantly, you have created irreparable Desquamination, which I'll explain in a second, of the GI lining, resulting in very poor absorption of water and nutrients. Desquamination means a loss of the lining. The word means flattening of the lining. I'll show you a picture here. I think the picture's probably in the textbook, but I'll show you a picture here in a second. Immediate cause of death: dehydration, electrolyte imbalance, and starvation. Because you are not able to absorb water, you're not able to absorb food, right? In your food, you need proteins, you need fats, you need carbohydrates, and you eat those things, right? You also need water, okay? Roughly speaking, how long you're going to live without water? 3 days. I remember the rule of threes, right? 3 days without water, 3 weeks without food, right? Good. And 3 hours without shelter in extreme environments, right? So that's a rule of threes. 3 hours without shelter, 3 days without water, 3 weeks without food, okay? So there's the 3 days without water, that's 72 hours, right? If you don't get medical treatment within 72 hours after about 6 grays of exposure, you 100% will die, okay? Because you now can't absorb water, which is the most pertinent thing right now, through your small intestine anymore. So how are they going to get water into your body? IV. They're going to get you intravenous administration now, okay? And now we can keep you hydrated, okay? And we can make sure you get the appropriate nutrients, especially sugar, through the intravenous. Give you dextrose, for example, right? We're going to make sure you get all the important stuff. We're going to get you the right electrolytes through the IV, right? So we're going to give you lactated ringers, the electrolyte bags, right? We're going to give you all the stuff that you need through intravenous administration. So that bumps up the lethal dose to about 7 gray. So now at about 7 gray, even if we do those things, you're probably still going to die, right? But at 6 gray, get me some medical treatment. I can survive that because you can keep me hydrated, right? You can keep me getting nutrients in, keep the electrolytes balanced. But you also still have to keep in mind, we also have to worry about opportunistic infection because the blood cell syndrome is also happening too. Okay. All right, so you go 1 gray blood cell syndrome, at about 6 to 7 gray GI syndrome. Okay. And then you've got a big range from there to the next syndrome. So as long as you keep me below about 50 gray, so from 6 to about 50 gray worth of radiation, it's all GI syndrome. Okay, you're probably still going to die, but you're not going to die from like your brain bleeding out, right? You're just going to starve, right? You're just going to starve and dehydrate, right? No big deal, and get bad infections, right? But at about 50 gray, okay, you now deal with central nervous system syndromes. Now, 50 gray, we're talking about huge amounts of radiation, right? Many lifetimes worth of radiation all at one time, okay? So big doses. I mean, right now, 50 gray, we're 50 times the lethal dose threshold, right? Which is 1 gray. Okay, so anyways, risk of death now, acute brain damage. The immediate cause of death, because you can't really hurt the neurons. They're hard to hurt, okay? The neural tissue that your brain's made of, but you can hurt all of the blood vessels in the brain, okay? Immediate cause of death, extreme intracranial pressure caused by edema, which is like fluid accumulation, as damaged blood vessels leak. Neural damage will occur from lack of oxygenated blood. So you can hurt the neurons, but not with the radiation. You're just going to hurt them by starving them from oxygen, suffocating them. Remember, Bergoni and Trabando say nerve cells are hard to hurt, okay? You can suffocate them, but you can't really hurt them with radiation directly, okay? But you can hurt their whole support system, right? You take the pit crew away from the NASCAR driver, right? And they're not going to be able to do anything with their car, right? The neurons are not going to be able to do anything without their support system, okay? Somebody delivering them oxygen, somebody taking away used up carbon dioxide, somebody taking away their nice little environment that they get to sit in, right? And just now putting them under extreme pressure because of all the bleeding around the area. Now they're going to die, okay? So you get death from pressure and lack of oxygen. Okay, so those are our three syndromes. Hematopoietic syndrome at 1 gray, GI syndrome at 6 gray, central nervous system syndrome at about 50 gray. Good. So all of these have a average survival time. Assume you've passed the threshold, you've got an average survival time. They're all life-threatening. Above GI syndrome, you're pretty much certain to die. Below GI syndrome, you have a high likelihood of dying, but they all have a mean survival time. It's the average time from an acute dose to death. It shortens with increasing dose. This is what we say the effect is inversely proportional to the dose. As the dose goes up, the times associated with the effect get shorter. So you get to death quicker as the dose goes up. Each ARS syndrome has a characteristic mean survival time. We don't have to guess at them. You just get to see them right here. So 2 to 8 weeks for your hematopoietic syndrome. So 1 gray to about 6 gray, you've got about a 2 to 8 week survival time. You might survive, but if you don't survive, you're going to die in 2 to 8 weeks. That's because, what are you going to die from with this syndrome? You're going to die from infection, okay? And infections take time. A couple of weeks, a couple of months maximum. GI syndrome. Now, I told you the rule of threes. That's something that I didn't write the textbook, so the people who wrote the textbook get to write different things. I say 3 days without water, 3 weeks without food, because it's easy to remember. They're going to say roughly 7 to 10 days without food, roughly 4 to 7 days without water. So we're talking similar orders of magnitude here, right? But slightly different actual numbers that these authors are referencing. But same idea, though, right? Days without food, week or so, weeks without water. Sorry, other way around. Days without water, weeks or so without food. All right, but anyways, what you die from with GI syndrome, your mean survival time is 4 to 10 days, because your highest risk of dying is dying from dehydration. 4 days. 3 is what I said, but you get the idea. Your highest risk of dying after dehydration, if we can just keep you hydrated with IV fluids, your next highest risk of dying is nutrients. Not getting enough, and it's mostly sugar, right? You eat sugar, fat, and proteins, right? The fats and proteins, your body can just pull those out of storage, right? And it has those stored in excess. But the sugar, right? Your body can pull that out of storage too, but it costs energy to do that, okay? So after a certain amount of time, you sort of run out of all your sugar storage, okay? And on top of that, ketosing, which is the process to get sugar out of storage, ketosing is harmful to the body and can cause pH imbalances in the blood and cause a number of other big problems for the body. That's why they don't recommend people ketose just randomly, right? You do it under guidance. Okay. If you don't know what ketosing is, just ignore what I just said. All right, but anyways, mean survival time for GI syndrome, 4 to 10 days. Central nervous system syndrome, 2 to 3 days. However, acute brain pressure can cause coma within hours. So, as far as the person's concerned, after a few hours, they're gone, right? But as far as medically, like brain activity, vital signs present, a couple of days is what they can last. Yeah. So, they're going to do everything they can, right? Somebody gets exposed to 50 gray or more, they're going to do everything they can. They're going to keep them on ventilation. They're going to get them on IV therapies. They're probably going to be in a coma by then, but we give them a couple of days of trying our best, okay? And if they don't survive it, which they probably won't, right, they're going to die within a couple of days. And within a couple of days, there's just nothing we can do. The heart's not going to be able to do its thing anymore. The brain's not going to be able to send signals to the body anymore. And we're effectively just keeping them artificially alive at that point, right? And then people get to make their decisions on whether or not to keep things going, which the smart thing would be to just stop things. Okay, good. So good medical advice is useful in those contexts, right? Okay. And again, without medical care, these all get much shorter. These survival times get shorter, right? Without any medical treatment. Okay. Let me show a couple other things here. as far as GI syndrome, so this photograph here, microscope image, shows the thickness of the lining of the small intestine of a rat, which, genetically speaking, we're very similar. Okay, we're mammals, they're mammals, right? So that's the lining of a healthy rat. B, this image on the bottom, is the thickness, same scale, the thickness of a lining of the small intestine after 2 grays delivered to the intestines of this rat. Okay, the rat's dead. They've autopsied the rat. And so these villi, these long folds of tissue that allow for absorption in the small intestine, are completely flattened or disquaminated after that exposure. I forget, does it say how long after exposure? No, but I mean, days or hours after the exposure. It's completely flattened. Now, body, and here's the other part of this. Like, this won't be able to absorb nutrients anymore, but the opposite effect will happen. The body fluids will leak out into the GI tract, leading to worsen. On top of not taking in more water, you're now actively losing water. Okay, so again, dehydration is going to be the biggest killer in the GI syndrome. Okay. Let's move on. Just to kind of circle back around to our threshold doses, because I was giving them out because I was going off of my notes, but here they are in the actual PowerPoint. Threshold dose for hematopoietic syndrome is 1 gray. That's where we get the lethal dose from, the LD threshold from. The LD 100 comes from the GI syndrome at 6 gray. And then just above 6 gray, everyone's still likely to die. Central nervous system syndrome's threshold is 50 gray. The note here, radiation levels for central nervous system syndrome are so high that manifest illness is reached within just hours. 5 to 6 hours. Again, they're also in a coma in 5 to 6 hours too. So they go from prodrome through latent all the way to manifest illness with only a few hours. Okay, so they feel terrible really quick. They're like, that wasn't so bad. Watch a movie. The end of that movie, they're now very, very sick in a coma. Yeah, not good. So there you go. The periods, the stages, these 4 stages, prodrome, latent, manifest illness, and death or recovery, shorten up the bigger the exposure is, inversely proportional to the exposure. Okay. One last note that I'd like to talk about are other early effects. Other early effects, local tissue damage from radiation can cause organs to atrophy in size as well as decline in their function. 2 other early effects that are useful, we've sort of listed them already, but just to kind of get them again, you'll want to work on remembering. I know there's a lot of like thresholds and then what happens after the threshold, but try to work on like practicing remembering these things, highlighting, flashcards, whatever, like just continually looking at these things. But it's gonna come up. I don't know exactly which questions are gonna come up when you get to the state board, but you're gonna get some questions about thresholds. Okay, they might ask about the LD 50/30 or the LD 100 or the skin erythema dose threshold. Right, you're gonna be asked about these, so do your best to start working on memorizing these thresholds. You only have to do it until you pass the state board exam, okay? Once you're past that, like me, I mean, there's a few that I have locked down because I teach this, but like I don't walk around remembering, the chromosome aberration dose, right? Or the hematopoietic syndrome dose just off the top of my head, right? I might, but I don't actively go around practicing these. But as a student, I need you to. Okay, I need you to go actively be practicing these. You should know these better than I do, right? When I'm sitting here looking at my notes and reminding myself about the threshold doses as I'm talking to you guys, you should have these locked down, okay? Because you're in the learning process right now. You get to forget it later down the line. Go ask your X-ray techs, what's the LD 5030 for humans? And they're like, what are you talking about, right? I haven't learned that in 20 years, right? But you guys will have it, okay? Until you don't need it anymore. All right, good. But you see how it all kind of helps build a good frame of reference, though, for what we'll actually do as X-ray techs, learning what happens well beyond the levels that we deal with, right? So you can like sort of more intelligently talk about what we're actually dealing with. So there's a reason for it. Anyways, other early effects. Erythema, a sunburn-like reddening of the skin, which is a common side effect of radiation therapy. At high doses of radiation, a second wave of erythema is followed by desquamination of the skin, in which ulcers begin to form. The threshold for skin erythema, which is called the skin erythema dose, or SED threshold, is 2 gray. So if you give the whole body 2 gray, what have we passed the threshold for? Well, I mean, I know we passed the threshold for skin erythema, but what have we also passed the threshold for?
No.
Not hair loss. Think whole body effects, the ones we were just talking about. Yeah, threshold for death, right? At 1 gray, or at 2 gray, we've passed the 1 gray threshold for hematopoietic syndrome, right? So they've got nausea, vomiting, diarrhea. They've got blood cell suppression in the active, and then blood cell suppression in the bone marrow, right? And whole body sunburn, okay? Followed by ulcers forming on the skin. So on top of like having the blood cells suppressed, you also are going to have like ulcers on the skin, which are openings now for infection to get in, right? So it's all sort of snowballing together. All right, skin erythema dose, 2 gray. And lastly, epilation, 3 gray. So give the whole body 3 gray. We've got nausea, vomiting, and diarrhea. We've got lethal dose threshold is passed. We've got hematopoietic syndrome. We've got acute radiation syndrome now. And all of our hair falls out. Okay, good. 3 gray, epilation dose threshold. All right, gang. That is everything I wanted to talk about today. This is a rare day where we actually made it through all of the information that I had planned. That means next time we get to jump straight into the late effects, which will take me the entire class. All right, there's no lab today, so you guys get to cruise on out of here. It's about 12:20 right now. If anyone has any